Okay, so good morning, ladies and gentlemen. Welcome to this instruction course on challenging FACO cases. So we have a host of very well experienced surgeons as faculty. So we have Dr. Amit Porwal, who is the member scientific committee of AAOS. So, and we have Dr. Sudeep Das, Nagar Hospital, Orissa, Dr. Venkatesh from Aravind Hospital, Pondicherry, who is the Chief Medical Officer, Dr. Haripriya, again, Chief Medical Officer of Aravind, our own indexing, and our world-renowned Dr. Ji Soon Fake from Singapore National. So, let me ahead with inviting Dr. Sudeep Das for his first talk on dealing with eyes, large and small eyes. Over to you, Dr. Sudeep.
Thank you so much. Yeah, thank you so much, Minu, for having me in your course. So I'll be speaking on FACO in eyes with long and short axial lens. To start with the hyperopic or even further like nanophthalmic eyes, the first problem that you'll face is IOL power calculations, and these have been found, Holiday 2, Barrett, and Offer-Q have been found to be fairly accurate in these eyes. Barrett right across the range of axial lens. The other problem with these is that they have a very shallow anterior chamber with possibility of angle closure. So in my practice, these people need...
Is your sound okay? Is your voice okay?
My voice is okay. Is it not clear? I'm not using external mic, but it was all right in the morning.
Okay, Sudeep, somebody says okay, I think you should continue.
You can come a little closer, that's it, that's good.
Yeah. So basically,
voice is okay, that's okay.
Yeah, it's possible that you can get angle closure when you dilate them.
Yeah.
So if it is, if they have a pretty mature cataract and all, I don't plan on doing PI in these cases. I don't dilate them till the day of the surgery, or possibly on the table itself to prevent angle closure. And the other thing is during FACO itself, because it's such a shallow anterior chamber, it reduces space for maneuvering and increases chance of endothelial decompensation. So if it's a hard eye, use IV mannitol if necessary, pars plana vitrectomy for those who have the experience in doing this. A very small pars plana vitrectomy will usually soften the eye. These eyes also do not dilate very well, and there is increased incidence of PCR, choroidal effusion, and expulsive hemorrhage. So if you see a change in the red glow, just stop the surgery, put sutures and get out. One thing that I would advise is using cohesive OVDs during rhexis. Nowadays, there are so many of them. And a spiral or a double rhexis with microforceps. Protect the cornea with a dispersive OVD. Nowadays, we get so many of them other than Viscoat, which are pretty good. Increase the bottle height and use relatively low vacuum and aspiration flow rates to prevent the anterior chamber from collapsing. And then iris tends to prolapse in these eyes, so place slightly more anterior wounds, both the side ports and the main wound, to prevent iris prolapse. And you have to match the wound size to the sleeve tip width perfectly. And also divide the nucleus into very small bits, because remember that the anterior chamber is shallow. You try to just divide into 4 bits and emulsify it, it is going to touch the cornea. And multiple Viscoat injections, and in the back FACO wherever possible. So this is something that I haven't done. Injection mannitol, yes, we give. Pars plana vitrectomy, yes, very rarely, but a scleral cut down is something that I haven't done at all. So if you want to know about it, there are enough videos and all available on YouTube. This was a very again, a very small eye, probably around 21, 22 millimeters. Cornea was also slightly smaller than normal, as you can make out. And you can see here how the anterior chamber is fluctuating. Look at that. Look at that. You see the iris, the pupil dilating and constricting, dilating and constricting. So actually at this point, I reduced the parameters, my vacuum and all that, increased the vacuum at the IOP a little bit. And remember that this is on a Centurion, and even then I'm facing such problems. So now after reducing the vacuum and AFR, it's a little better. I've increased the IOP a little bit. So you can see that it's not fluctuating so much now. So it's very important that you pay attention to these small things that you see. And if you, and one shouldn't take, start feeling that, no, it's okay, I'll manage, because that is when you end up in trouble. And in these small eyes and all, it's very difficult doing secondary procedures if you have a nucleus drop. And this is absolute nanophthalmic eye. It's a 19 diopter axial length with a 34 diopter IOL. And it's a fairly dense cataract. But even in this was a mannitol was already given. So you can see that even in these eyes, if you take proper precautions, the anterior chamber can remain pretty stable. Like here, unlike the other eye, you don't see anything happening at all, though it's a much smaller eye. So basically in the other eye, a mannitol was not given. Here a mannitol has been given. So I think anything which is 22 millimeters or less, it's probably better to give mannitol. And then there you saw me injecting Viscoat again. Of course, the video is a little speeded up. And without complication, this has been completed. The problem with high myopes is a lot of them don't tell you about the history of refractive surgery or VR surgery. So if it's a LASIK, then you can make out. If it's a PRK, it's almost impossible to make out that he's had a surgery. So be very clear about it, ask them repeatedly, see that they haven't had any of these surgeries, because if it's refractive surgery, IOL power calculation is going to go completely haywire. And in the VR surgery, the prognosis may be bad. So I'll explain about the possibility of amblyopia, especially in those people who have anisometropia, possibility of developing RD, macular degeneration, and there still may be errors in IOL power calculation. Do both optical and immersion if you have both. And these are the ones, the formulas which are very clear. I basically use Barrett's in Universal 2 and everything. And try to do the surgery on a topical, mainly to prevent globe perforation, because these are long eyeballs. During surgery, maintain adequate anterior chamber depth throughout the capsular axis with an OVD to prevent capsular tears. Again, minimize incision leakage. That basically, if the iris starts prolapsing, it will constrict even more. Decrease the irrigation bottle height and increase the flow rate relatively to avoid deepening the anterior chamber. And in the case of lens iris diaphragm retropulsion syndrome, as LIDRS as we call it, use any instrument like a spatula, cannula, or even irrigation to just break the contact between the pupillary margin and the lens. So this one, I'm basically showing just how it's done. So inject viscoelastic, otherwise there is sudden deepening. So I haven't switched on here. You go in, I haven't switched on the irrigation. The phaco tip is inside. I go in with the iris. I switch on the irrigation only after separating. If I see the iris moving again, you again can go between the iris and the lens and break the LIDRS. And these very highly myopic eyes, usually you get these only in 3-piece. You get lenses only in 3-piece designs. So this is again, it's a 1 diopter lens. I think it's a 30 odd millimeter lens. Sorry, axial lens. And in these cases, though I do topical, I would sometimes prefer to use xylocaine or one of those things to, anesthetize the iris a little more, because they tend to have more pain than normal people. So you can see here that I'm using IOP, which at that time was low for me, 44, but now it'd probably go down to about 35 or something. But with the vacuum staying at the maximum of about 300, 350, the eye remains pretty stable. So this is another thing that has been described. I couldn't find a video. I had a video of that. I can't find it. So basically, if you see that there's a lot of LIDRS, you can apply just a single iris hook on the inferior quadrant and go ahead with your surgery, and there's no problem at all because the iris is permanently away from the lens. So the take-home points in short axial lens: ensure that there is a soft eye before surgery. Use IV mannitol massage, pars plana vitrectomy. If you are pretty confident about it, you can even do a scleral cut down in emergencies. And relatively high infusion pressures, moderate AFR and vacuum. In long axial lens, avoid excessive massage if you are giving a block, but preferably do it under topical surgery to avoid a very deep anterior chamber and mainly to prevent a globe puff. And low infusion pressures, relatively high AFR and vacuum. And if the bag is loose, usually it is, reduce parameters before the last piece and use a single hook in presence of LIDRS. Thank you so much.
Thank you, Sudeep. You have covered almost all the possible points regarding short and long eyes. So let's move on to the next talk by Dr. Venkatesh, who will talk to us on posterior polar cataracts.
Hello, friends. Welcome to our instruction course. I first thank Dr. Minu Mathan for giving me this opportunity to talk about how we manage posterior polar cataracts. So managing posterior polar is always very tricky because many of the time they all look like posterior polars, but they're not maybe really posterior polar cataracts. So whenever we see an onion ball-like appearance like this, we suspect that they may have dehiscence and complex surgeries, but many of them may not have. So the challenges are there is a high risk for PCR because of the fragility of the capsule and the adherence of the opacity to the capsule. So even at the last stages, you can have dehiscence. And additionally, there are surgical challenges because sometimes they may have very soft or sometimes they may have a very hard nucleus. And nucleus rotation may not be safe. So you may have to do a phaco without rotating the nucleus. And the other important challenge is many of these patients are visually disabled at a very young age. So they are in their productive lifetime. So you have to be very careful in doing surgery without any complication. So I would like to say PPC like this: planning the procedure and preparing the patient, telling them the risk, preventing a PCR or if possible a lens drop, and choosing the appropriate technique. There is a very dense cataract. I prefer to do a small incision cataract surgery than even a phaco in some of these posterior polar cataracts. It's very important to talk to the patients before surgery. You have to do that. It may take longer than normal surgery. The possibility of a nucleus drop, planning a secondary IOL later, any vitreoretinal interventions if there is a nucleus drop, and also if there is fibrosis, the possibility of doing a YAG laser a little later. And many of the times these young patients may have amblyopia also, preferably a peribulbar or a retrobulbar, or even subtenons anesthesia. We routinely do subtenons now. So where we do subtenons is anybody where we have seen a dehiscence on anterior segment OCT or on a slit lamp, or if the PPC is greater than 4 millimeters. If it is less than and we don't see any dehiscence on ASOCT, then we prefer a topical anesthesia. When you're doing a phaco, I think it's good to do the side port incision, gentle decompression done before making the main port, and avoid over pressurizing the anterior chamber at any stage, and try to use a heavy viscoelastic, especially in young patients, to counteract the scleral elasticity. Preferably a large rhexis because sometimes, following a dissection or a delineation, it can prolapse outside into the anterior chamber and make your surgery easier. Or if you want to manually prolapse also, you need a slightly bigger rhexis. But at the same time, you should have an adequate rim so that you can do a sulcus fixation of intraocular lens. Hydro is always a dilemma, because you cannot do a hydrodissection, but hydrodelineation is ideal. But very careful, hydrodelineation should be done because by chance you cannot hydrodissect, and also avoid a vigorous decompression of the capsular bag. And definitely you should avoid any rotation of the nucleus. So this is a technique which was described by our own Dr. Abhay Vasavada. It's a brilliant technique. I do that as a routine to many of my patients. So I do this nice trenching and then do an inside out delineation. So you have to do it from inside after you have trenched the central part from either side. So this really helps you to make sure you do only a delineation and there is no fluid doing and cortical cleaving hydrodissection. And make sure your parameters are always slow. You have to do a slow motion phaco here. Multiple techniques described by a lot of people, depending upon your experience and things. For a soft cataract, you can do aspiration. For a harder one, you can go for phaco chop, but without much rotation. So this is a nice technique, again, reported by our own surgeon, Dr. Rafik Vajpayee. It's a beautiful technique where you do a layer by layer phaco. So here you can see in this case, there is a nice posterior polar and of course already a dehiscence is visible. So adequate rhexis, not small, not big, is done. And then absolutely no any hydro procedure is being done. If you're just trying to do layer by layer. So you can see all these parameters are now aimed for a slow motion phaco. Then I'm using a Sinskey hook to first gently emulsify the central nucleus. So I'm just dragging to the center and then gently emulsifying it. And before coming out, we have to make sure the chamber doesn't collapse at every stage, especially when you see a dehiscence. And then next stage, we are trying to remove the epinucleus. So this is ideally done with a bimanual so that you have a control over your fluidics. So you have to keep the fluid away from the dehiscent area so that you don't have any entry of fluid into the vitreous. So whenever you are coming out, it's to make sure that your chamber is reformed with viscoelastic when you change hands like this. And then you do this layer by layer phacoemulsification. First the nucleus, then the epinucleus, and then finally cortex. So definitely by doing this, you can't prevent a PCR because it's already there, but you can prevent the extension and also any drop of nuclear material, like in this case. So whenever you have dehiscence or a possible dehiscence, epinucleus and cortex removal is very critical. You have to lower the bottle height, try to pull the cortex tangentially. And even sometimes you can do a dry technique of syringe stripping, which helps, really helps. And you keep the central area attached till the last stage and avoid any kind of polishing of the capsule. The opacity removal, if it is there, it's good. You can try to remove, or you can do a primary posterior capsular rhexis sometimes, or you can leave it for an YAG laser to be done at a later stage. In case if you have a PC tab, like what I said before, the remaining nucleus, if you have a big chunk of nucleus, you may have to convert to small incision, or you have to change to slow motion parameters. And if you are confident, you can remove the rest of the nucleus. So vitrectomy, as usual, in any case, how you do an anterior vitrectomy. IOL implantation, use a cohesive viscoelastic, avoid the IOL or instruments pressing on the posterior capsule. Preferably, you use a 3-piece lens. If your dehiscence is small, not extended, you can still use an Acrisoft single piece, which has got a very good memory so that you have a controlled release in the bag. Otherwise, you go for a 3-piece intraocular lens. Here, I'm just quickly showing you 2 scenarios where there is a dehiscence here, but we know the extent of the dehiscence, which is not extending to the equator. We have a controlled release of the Acrisoft lens. The memory of this lens really helps you. It doesn't unfold very quickly. So you can gently push it into the bag and then without enlarging the capsular opening, you can implant the lens. But if you have a big opening like this and it is also running to on either side, I think it's best you go for a 3-piece lens. 3-piece lens in the sulcus and an optic capture would really work. So ideally, now people who have lost touch in using a 3-piece lens should practice once in a while. To do this, even in a wet lab practice will help you. Here I'm using a side port irrigation just to avoid a lot of viscoelastic there. And then the lens, one of the haptic goes to the sulcus, and then you rotate the rest of the lens into the sulcus. So this needs a little bit of practice, but it's a nice technique to do. And then you capture the optic into the capsular opening. So again, I would like to thank Dr. Minu for giving me this opportunity. Thank you.
Thank you, Dr. Venkatesh, for very nicely covering the topic on posterior polar cataracts. We'll come to the questions and discussion at the end if we get time. So we'll move on to the next talk by Dr. Amit on white and black cataracts.
Thank you, Dr. Minu, for making me a part of this instruction course. Dr. Minu has been my teacher. Actually, in this course, Dr. Minu, Dr. Venkatesh, both are my teachers and mentors during my days in Arvind, and whatever I learned is from them. So, coming to the topic on toning down the mature and black cataracts, I have no financial disclosures to be disclosed. So, what are the challenges one sees when we are doing this black and hard cataracts? There's a poor visibility of the anterior capsule. There's a paucity of the epinuclear layer, which is not there. The posterior capsule is very fragile. The chances of PCR and nucleus drops are quite high. The zonules are quite relaxed, and there's a longer phaco time at high energy levels. There's a risk of corneal endothelial damage, and there is the risk of mechanical or thermal injury to the iris and the cornea itself. So usually these conditions are associated with ocular and systemic comorbidities like deep-seated eyes, compromised corneas, and poor dilating pupils. So many patients with these mature and dark cataracts are systemically unhealthy, and they also have a very poor anesthetic risk. So coming to the preoperative evaluation to help and plan intraoperatively, consider the following points. Look at the endothelial cell count, look at the antechamber depth, what's the zonal stability, look for the pupillary dilatation, do a B-scan if the fundus is not visible, and do a immersion biometry, which is a must. So coming to the few videos on how we are going to handle this cataract basically. So the dictum is generally I'll stain both my side ports and the both my side ports and the anterior capsule with the help of trypan blue. And most of the time these cataracts are mature. They can be intumescent. They are hard cataracts. So what I do is I try to shape my rhexis depending on the type of cataract I'm encountering. So you either make a large rhexis or make a short rhexis. And when you use a sharp chopper, you can use a horizontal chopper or a sharp tip vertical chopper. Always retract the sleeve posteriorly. You saw I was demonstrating that at least 5.5 to 2 millimeters of the phaco tip should be exposed. And whatever technique you are familiar with, go ahead with it. So this is a stop and chop technique. And when you saw that the central trench was being made, so once the central trench is being made, you make sure that each and every leathery fiber, they are separated. So you saw this was a very long sharp chopper. It's almost about 1.5 millimeter. So the sleeve is retracted, all the loose cortex is aspirated. The rhexis is a bit small because it was an intumescent cataract. I didn't want the rhexis to get away. So once a small rhexis is fashioned, now I'm going to emulsify the cataract. And you can see that the chopper is such a sharp chopper. I'm going for a direct chop. So the trick is you get a good hold. Lift the cataract towards the center a bit, and then try to chop. Sometimes the hole might be loose. Don't worry. You can do multi-level chopping. You can see these all leathery fibers which are nicely attached. You have to make sure that they separate. You might not be able to separate throughout from one half to the other half, but try to do multiple choppings. You can see what I'm doing is I'm doing a multiple direct chop. So multiple small quadrants are created. There might be a central nucleus, but then don't worry. You can then emulsify the central nucleus later end. So what you aimed at is you should have all fibers separated. All the pieces should be separated from one another. And then once they are separated, and then it will be easier. Sometimes you can just emulsify one of the quadrants so that you have enough space for the phaco tip to be phaco probe to be there into the capsular bag and go ahead with the cataract surgery. So this was the way this type of cataract is managed. Also going to demonstrate the other way. So how do you do it? You just do chop, trip, and free technique. Now, how do you do it? You can see on the right hand side the slow motion video which I'm showing. The cataract is not so hard, only the central nucleus is hard. But for demonstration purpose, I'm showing that you just after dividing the quadrants into small pieces, you hold one of the piece, lift it towards the center, take a sharp phaco chopper behind this piece, and try to separate that adhesions what is there. You have to be very careful when you are doing this. You can take an horizontal chopper, go behind this piece, and try to separate the adhesions. This is the chip, trip, and free technique. So once this piece is freed, then you can emulsify it very easily. So this is very essential. Sometimes, I mean, there's no one technique which is going to suit all. You have to change your technique intraoperatively depending on the type of leathery fibers you're going to encounter. So coming to the next part was the hypermature cataract with these calcified capsules. You can see this is two cases of hypermature cataract. But what is important is the staining of the anterior capsule is very important. Whatever the loose liquefied cortex comes, you aspirate it, use a high density viscoelastic substance, and you can inject this viscoelastic into the capsular bag also. So by doing that, you maintain the capsular bag inflated, and then you can do a gentle rhexis. When you're doing the rhexis, make sure that you support the nucleus below your rhexis, below the capsule where you're proceeding with the rhexis. So that gives like a fulcrum to proceed with the rhexis. Now, as I told you earlier also, that I always stain the side ports. The reason I stain the side ports, how do I stain it? Once you put the tryptophan blue dye from one side port, you try to wash the dye through the other side ports. So whatever the dye leaks out from the anterior chamber through the side ports, they will give some staining to the side port, and that will help you in your cases. So once the capsular rhexis is done, then you can do a solute chop. You can see in this how the solute chop is being done. You can go with the direct chop or a solute chop. Solute chop, you just put a visco behind the nucleus, above the nucleus, inflate the bag, and then you can see that the phaco probe is introduced now. You need a sharp chopper. You have to retract the sleeve, and throughout the procedure, whenever there was a few air bubbles had come up, so you just engage this space, make the nucleus vertical, and in one go you can crack through and through. You should have a nice hold. To get a hold, other thing is the infinity users. I'm an infinity user, but when you want to get a direct good hold, what I use is I use the longitudinal phaco and not the torsional phaco. With that, I get a very good hold, so I can chop clearly. And in this type of cases, you can see that the rhexis is small because I don't want to take any chance. Once the IOL is injected, you can refashion the rhexis to the desired size and shape. So any type of mature cataract, you can make a small rhexis so that you don't get away. You don't want the rhexis to get away. Emulsify the cataract, and then you can inject the IOL and then refashion the capsular rhexis to the desired size and shape. So for this, the trick is you need both the micro rhexis, the micro varnas, and you should be used with both the right hand and the left hand as well. So this is the way I'm going to handle. So this hypermature cataract, that is a solute chop which I discussed. Wash carefully for the last steps. Usually in these hard cataracts, some pieces are there behind the side port or behind the phaco probe. So sometimes what happens is after you have injected the IOL, when you're doing the visco wash, suddenly you will see these pieces floating from the side, below the side port or from the sulcus. So you have to be very vigilant that you do a proper irrigation so that none of the pieces which are there behind the sulcus or anything come out. But this is the last video which I'm going to show. So the staining of the capsule, as I told you, is very important. Whenever you are proceeding with your phaco, you don't want any wound burn. This is very important. This was a very hard cataract, mature hard cataract. I was doing with the proceeding with my phaco, but my assistant forgot to put a chill saline constantly on the tunnel. So when you don't do that, then what happens is you land up with corneal burn. So this is what happened in this particular case. You can see this fish mouthing of the tunnel which is there. And then you can see the leakage also. Why this leakage is there? Because of the fish mouthing. So whenever you have a fish mouthing, please suture the tunnel. Don't leave it like that only. And how you're going to avoid the fish mouthing? By using proper energy settings and by putting cold chill BSS on the phaco probe. So the last tips I've already told you all. Be prepared for iris hooks, capsular hooks, and also whenever you want to convert, you should be able to convert to SICS also. So the 10 commandments for toning down the mature and black cataract: use tryptophan blue to stain the capsule, aspirate the liquefied cortex if any, size the rhexis according to the type of the cataract, and then refashion it after implanting the IOL. Use longer and sharper chopper to facilitate embedding the dense nucleus without displacing it. Retract the irrigation sleeve by 1.8 to 2 millimeter. Alter the angle of the vertical chop slightly and approach the immediate phaco piece diagonally. Transect leathery fibers at the posterior layer with the chopper. Divide the nucleus into smaller fragments to emulsify them securely. Use viscoat to maximize endothelial protection or a dispersive OVD behind the last remaining fragment to create artificial nucleus. Thank you.
Thank you, Dr. Amit. That was very crisp. And can you
I'm just
share your
I just
screen,
stopped
please?
sharing my screen.
So we'll
Just 1 minute.
yeah. So next we'll go on to my topic on soft cataracts, and maybe if possible we will touch upon some topics which we have missed also. So let's talk about soft cataracts. So soft cataracts, we consider them as easy, but then what are the problems of a soft cataract? So even if with the minimum power, if you try to catch these soft cataracts, it just eats through. So you don't get a hold there in the center. And another problem is that when you go further from the center, you go to the periphery very easily, and with the thin nucleus, you can get onto the PC very fast. So this is a problem. So here I'm going to show you this chopper which I'm using. Is just a plain straight chopper. That's it. It is a 1.75. You get it in 2 sizes. Appasamy makes it for me. I have no financial interest in this. This is the other end of the chopper. For that is the sharper one which Amit showed you now. That I use it for hard. So this one I use it for most of my soft cataract. I will show you in some of the techniques. There are 3-4 techniques that you can employ in soft cataracts in favor to do phaco. I would say hydrodissection is the most important, and it's a key. So multiple delineation so that it rotates very, very well. So once that is done, we take out the epinucleus from the top, and then with the tip little more exposed, I am making a very and then separate 2 halves. Once the 2 halves are separated, only thing is make sure you don't go through the piece, because a little more of energy and a little direction downwards, you can go through the posterior canal. Vacuum, hold it nicely, lift it out of the bag and emulsify it off. And similarly, the other part. Initially, don't use phaco. Go approximate the bevel of the tip to the nucleus piece to emulsify. So here is another way. Very soft cataract. As I said, multiple hydrodelineations. Hydrodissections, make sure that it rotates very, very well. And the same solute which pull out. But once one pole is out, it is positioned in such a way that the pole is towards the because I am going temporal, the nasal part is out. So the chopper, soft chopper, the nucleus with just vacuum, touch it. You don't have to enter the nucleus at all, and move the nucleus to these 2 instruments towards each other, the chopper behind and the phaco needle in front. So this is typically, and you can subdivide. Once you divide it into 2 or 3 pieces, that must be enough. And after that, you can emulsify it off with a lot of visco in the anterior chamber. It's finished just like that. So the periphery of the delineated nucleus, hold it there and push and pull. Pull with your chopper and push with your phaco probe. See, initially to learn this, you can make a small burrow and move it from the periphery to the center. While coming to the center, you have to be a little deeper, because the center is slightly deeper. And once you finish that, make sure you have rotated. So choose any of these techniques, do it in multiple cases and see which one is suiting you. And choose one of those. See, this is one thing, one step we can verify rhexis. Take out the epinucleus, hold on to the edge of the epinucleus. with continuous vacuum and minimal continuous energy. Sometimes epinucleus comes out first, sometimes it comes out by itself. So this is called carouseling. This is a published technique. Carouseling within the bag is also possible. Even with longitudinal, with high hyperpulse, we can do this. So we move slit lamp, and it has to be identified, because sometimes we are so happy seeing the cataract and you miss the cornea, look through the cornea and see only the cataract, and you miss and most of these cases I do a specular and show the patient and tell them that there is possibility of a delayed visual recovery, and you may need more medications because of the problem there. So I am to cover the endothelium in throughout the surgery. So at the beginning itself, I put viscoat. Fill half of the anterior chamber with this close to the endothelium, and then, because I like the soft shell, on top of the anterior capsule, and push the viscoat against the endothelium. And then after the good rexes, chopping is the one which I do. I complete all the chops within the bag. I will stop phaco and then put in more viscoat, and then continue and fill up the bag with HPL and push the viscoat onto the endothelium and chop it into very small pieces. Take one piece and not let it fly around. If it flies around, it means that you have lost viscoat in the bag, in the anterior chamber. And so please reform the anterior chamber with more viscoat and emulsify it. Energy very low and flow and vacuum also moderate, so that you don't create turbulence inside the anterior chamber. And at the end, IOL implantation with sodium hyaluronate, so that it can be compressing from the angles in the anterior chamber. Take some time to aspirate. And also from the endothelium, if you can notice here, you can see the viscoat getting aspirated from close nucleus or epinucleus chips, which can get coated with the viscoat and stay within the angle or under the iris. And so aspiration of the viscoat and this is a penetrating from a fresh corneal wound here and the intralenticular foreign body. So we put 3 sutures to the wound, and so that the chamber is tight. So this is gone through microrhexis forceps to hold on to that and take it out as atraumatically as possible, so that you retain the iris and the rest of the anterior capsule intact. And align is, you identify here there is good red glow. That's why I don't use a trypan blue. Otherwise, we should use trypan blue and stain the capsule and see, and make a nick on the discontinuous part of the anterior capsule and join it to the other side of the discontinuous rhexis here. And you can use an IA. You can use a phaco probe, but with lower bottle height and lower parameters. Just use vacuum. I am using, finish that area, and you have vitreous there. Otherwise, you have to do a vitrectomy here. Luckily, there is no triamcinolone, and see whether it is vitreous is there. Do a vitrectomy there. It's released. So you can see the hole which is already there. That is okay. It's horizontally away from the area of rhexis tear. Or you can, the visco has to be aspirated from below, and this remains in position. And this patient has to be treated accordingly. Retina has to be evaluated after the surgery, and patient on close follow-up. Here again, this is a penetrating injury. Body has been detected. So we are with VR backup. and we stain the anterior capsule and see that there is possible for an IOL implantation, because we know that the PC is open. So rhexis can be done excluding this end. When we start aspirating, you don't know, it's near total cataract. So we don't know how much of the cataract, and continue aspirating till you get vitreous. So you can clear up that area at some point of time. It's good to go pars plana and do the anterior vitrectomy and complete the aspiration of the body is taken out, and because you can, or a 3-piece foldable lens in the sulcus, and follow up these cases as we had discussed. Move on to Dr. Haripriya. Dr. Haripriya is a very prolific phacosurgeon and capsule stabilizing devices. To you, Dr. Haripriya.
Thank you, Minu. So I'll be talking on lens subluxation. So not all patients with subluxations would need surgery. Only if the patient has subluxation with cataract, or if the patient has defective vision because it is the phakic status, or there is diplopia because the lens is dissecting the pupil, or the nucleus is in the anterior chamber or vitreous cavity.
Your PPT is not on.
Oh, it is not?
Your PPT is not on. Is
Yeah.
it on? Is everybody else able to see?
Yeah, you open the PPT before and then share again.
Yeah,
It was not
Yeah,
on.
you open it first and then share, please.
so it's working now. It's fine.
Yes, ma'am.
Yeah, this is fine. Yeah. Full screen, please. Yeah.
The slit lamp examination, one has to look at the cornea, status of the iris, pupil, any mydriasis, anterior chamber depth. Presence of vitreous is also common in patients with lens subluxation. And look for phacodonosis. This will give an idea if it's a more diffuse subluxation. If it is localized, we'll have to look at the degree of subluxation. If there is gross phacodonosis, it's always better to have the patient lie down on the supine position to see if the lens is following back, in which case it's better to have the patient refer to the VR surgeon. So in terms of approaching a patient of lens subluxation step by step, capsulorhexis is very critical. So one would have to use a good viscoelastic, a high molecular weight viscoelastic. The blue can be used to stain the capsule, both to aid the rhexis and to be able to insert your hooks and the CTR. One would also like to initiate the rhexis away from the area of subluxation. So this patient, the subluxation is significant, but if you note, the lens is not too wobbly. So it's adequate to go with your cystotome for the rhexis. Start the rhexis at the area where the zonules are intact. This way one will have counter traction. And as you progress to the site where there is subluxation, it has to be slightly smaller because there's a high chance of extension to the periphery if you make it large on that site. An important device which we use would be the capsule tension ring, which is extremely useful for patients with mild to moderate subluxation. The CTR comes in 3 different sizes. Most often we use the 11-13 size. The 11 size will be the size of the ring within the capsular bag. In myopes, we could go for the larger, and in patients with microsclerophilia, we'll go with a smaller CTR. So in terms of insertion of the CTR, the timing would be, you would like to delay the insertion as much as possible, but as early as possible based on the requirement. So because cortex wash can be a hindrance when you have the CTR in place. So for mild subluxations, I would like to delay the CTR placement to up to the just before or just after the lens placement. The other very useful device is the capsule retractor. I use iris retractors as well, the ones made by Grieshaber for the same purpose. This would help in rhexis completion and CTR insertion. This would be inserted at the area of maximum zonular weakness, and this can help both for the phaco part and for the lens implantation as well. So even if one does not use it for the earlier steps, one can consider using it during the phaco or in the lens placement. So this patient has a little more tilted lens compared to the earlier one. I'm using Viscoat here to try to push the lens back, preventing vitreous prolapse, and to have the lens move flat. I normally do my rexes through the main tunnel, but here I like to go in through a side port, so there's less chance of any visco escape. Again, the rexes is smaller on the size of the subluxation, because once the bag gets centered after you place your CTR, this would be correct. So one will have to make a slightly smaller rexes here than the normal patients, because there is a higher chance of rexes extension. For bag stability, I'd go ahead and place the hooks before placing the CTR. Now this I would do before doing the hydro dissection, because this way one can see the rexes margin clearly. So one hook for every 2 clock hours is what I would suggest. So about 3
हाँ,
hooks
मीटिंग
for
में वो
about,
रात को बात करूंगा या कल
about 6 clock hours.
कुछ इमरजेंसी है क्या?
So we have about
AIC चल रही है, मैं अगले हफ्ते मिलूंगा.
yeah. Amit, I think your mic is on. You may have to.
रात में मेरा सेशन, रात में सेशन है, मैं फोन कर लूंगा जब फोन करूंगा ना, दिखाऊंगा.
So the hydro dissection is done after the hooks are placed and the CTR is implanted after that. This way the cortex, the chance of the cortex getting entangled between the CTR and the bag is lesser if we do the hydro dissection earlier. While inserting the CTR, ensure that the leading haptic goes in the bag. I prefer to have the manual insertion technique. One can also consider using the goiter or the single-use injector as well. But if you're using the manual technique, go into a side port and have the leading eyelid go into the bag under the rexis margin. The rest of the ring is then gently nudged forward, and the trailing eyelid one has to take care to ensure it goes in the bag. So before the trailing eyelid is released, stabilize the CTR from the outside using a Sinskey hook. So one can use a Sinskey in the non-dominant hand through the opposite side port, stabilize it from the outer side of the CTR, or you can also use the eyelid on the trailing haptic to hold on to the trailing eyelid and then release it in the bag to prevent it being released in the sulcus or in the anterior chamber. So in patients with more severe subluxation, one will have to use the modified ring or use a capsule tension segment, which is like a 5 millimeter ring, and this additional loop on the CTR can be fixed to the sclera for better stability. So before the Sioni ring is being placed, the ring is, you have a tenoprolin suture which is passed through the ring or the eyelid, and the suture is then brought out to the sulcus above the rexis margin, and the knot is tied on the sclera. This way the IOL capsular complex gets centered during and following surgery as well. This is a patient where if the lens is slightly tilted, there is gross subluxation. So rexis is a challenge here. So I initiated with the cystitome, but then continue with the capsular rexis forceps, again making it larger away from the area of subluxation. So the goal here is to have a rexis to be able to fixate the bag using a Sioni ring. So once the rexis is completed, I'd like to stabilize it with the hook, which can again be a challenge in patients where the lens is tilted. So even if it's not tilted, if there is an issue in hooking the rexis margin, one can stabilize the bag using a spatula with the non-dominant hand, lift it, and then hook the iris hook or the capsule hook on the rexis margin. So the bag is now stabilized, it is centered, but there is no CTR I have placed here in this patient. The hydro dissection is being done, and then the phaco is started. So in terms of phacoemulsification in these patients with lens subluxation, one has to have very careful setting, slow motion phacoemulsification. Of course, we have the benefit of good machines today. I'm using the Centurion system. IOP is about 40. So we don't want too much of lens movement. So you want to be very gentle. A good hydro dissection is very useful. Using adequate power and vacuum, the lens is broken down into small fragments and aspirated. The goal here is you don't want any vitreous prolapse, number one. Number two, you don't want the bag to collapse, which can also happen because this patient, though it is being stabilized from above with the hooks, the equator is free because there is no CTR. So if one does want to use a CTR to aid in phaco, we can use the option of CTR before phaco and then use a capsule tension segment to stabilize the bag to the sclera. The cortex aspiration with the coaxial irrigation aspiration again is a challenge, even without the CTR, because the bag is very weak. So very careful aspiration, very gently. I'm just holding the anterior leaflet of the cortex and aspirating it out, which is interspersed with injecting viscoelastic between. Because this way you can prevent, you can push the bag back and then go back to aspirating the rest of the cortex. The Sioni ring is before it's being implanted. I pre-thread the loop with a 10-0 proline suture on 2 long curved needles. Insert the leading eyelet. While inserting, ensure the convex portion of the loop is introduced. So a 2.8 millimeter would be required to implant a Sioni ring. So the convex portion, that way you don't have it flexing out. Insert the whole ring, again guided with a second instrument to ensure the trailing eyelet is as well as released within the bag. And then one will dial the loop to the area of maximum subluxation. And the loop is then brought out up above the bag onto the sulcus. So the 2 suture needles which are out to the wound have to now be brought out to the scleral flap. So here I am creating the Hoffman's pocket instead of a flap to create the space to tie the knot of the sutures. So to fix the ring to the sclera, I'm passing a 26 gauge needle and receiving the needle tunnel. Second needle also will be passed in a similar fashion, about 1 millimeter from the main, the first needle. The second needle is also passed. This is about 1 millimeter from each other, and through the Hoffman's pocket, the suture is looped.
Sorry to interrupt, ma'am.
Pardon?
Sorry to interrupt, ma'am. Your time is up.
Yeah, I'm going to be finishing.
Okay, that's
Yeah, I'm going to be finishing in a few seconds.
Okay, ma'am. Okay.
Yeah, so and then tying the.
it's okay. Carry on, Haripriya. We have some time, so we'll carry on. Let's finish this.
Yeah, this is the last case. And then the pocket is closed. And again, though the hook was not used earlier, the hooks are being placed again. A 3-piece IOL is then placed in the bag. Again, a 3-piece IOL is placed here because even in spite of the Sioni, there's a chance of lens subluxation dislocation. So to aid in iris or scleral fixation, a 3-piece is preferable in patients with gross lens subluxation. After which the hook is removed and pilocarpine is injected to ensure there is no vitreous in the anterior chamber and the eye is closed. So this is another patient with 2 loops which has been implanted if there is a more gross subluxation. So post-op, you'll have to follow up the patient for any uveitis. Raised IOP could be a concern. Look out for capsular phimosis early post-op and PCO late post-op. And decentration can also be an issue in these patients with severe subluxation. Thank you.
Thank you, Dr. Haripriya, to making it look so easy, though these are the toughest possible cases to be done. And can we invite Dr. Suven for the next presentation on small pupils?
Thank you, Minu, for this wonderful opportunity, for this wonderful course that you have every year.
People, so small people to cool.
Yeah, so I'll just share my screen. Is my screen visible? Minu, is my screen visible?
Yes,
Yeah,
yes, please.
Thank you.
Very well.
So I'll start. So after this wonderful talk by Dr. Haripriya, most of you will have your heart in your mouth, and I'll keep it a little easy on you so that you can sit back and relax. So I'll be speaking on hooks and rings in small pupil and IFIS. I have a financial interest in the BX Pupil Expander by virtue of my holdings and MedInvent devices. And I acknowledge the contribution of Dr. Deepak Magur in lending his video. Now, I would like you to all to ask yourself, if you have a cataract and a non-dilating 4 millimeter pupil and a very skilled surgeon is operating, one among us over here, what would you prefer? The surgeon use only skill and no device, or the surgeon use pupil device and skill? I guess availability and cost both are not an issue. So most of us would like to be safe than sorry. Now, can we use preoperative pupil dilation as a predictor of IFIS? Well, this was a paper in 2011 by Alessandro Casaccio and co-workers. The conclusion was for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha blocker treatment. Is there a risk of IFIS in India? Some people tend to ignore that? Well, from this study by Dr. Shilpa Goel and co-authors, it was found that the risk of tamsulosin intake and IFIS are both higher in India. And to add to tamsulosin and alfuzosin, hypertension was an important risk factor. That's a large number of our patients. Now, that's the long list of drugs that can cause IFIS, and of course, systemic conditions as common as hypertension, diabetes, chronic heart failure. So no amount of history taking can prevent surprises. And intraoperative myosis is unpredictable. Let's come to terms with that. So when we use iris hooks, our pupil expanders, we need to have a disciplined approach. We need to consider that every eye is a potential IFIS candidate. So we need to reduce the threshold for using a pupil device, and we need to keep a reasonable stock handy always. Viscoelastic injection, where and how, I'll be talking about that. We need to test and distinguish the elastic from the non-elastic pupil. That has a significance. We'll come to that again in detail. We need to understand the choice of pupil device, which would depend on the elasticity of the pupil mostly, and how you wish to tear the rigid pupil. And how big do you want the pupil to be? I mean, how much of the cataract we want to see is different, and how much is required to do a surgery is what we should be bothered about. And of course, we should know the relevance of the pupil devices and IFIS. Specific iris hooks and pupil expander tips is something I'm going to talk about. So when and how much of viscoelastic do we use, whether we use iris hooks or pupil expanders? Now, if we use viscoelastic in front of the iris, we tend to plaster the iris to the lens cap, so that leaves no space for the iris hooks or the pupil expander. That's counterproductive to our cause. So we need to inject viscoelastic under the pupil margin so that we can lift off that pupil margin slightly, and that makes enough space for the iris hooks or the pupil expander. The slight bowing of the anterior chamber helps in tucking the flanges of the pupil expander or the iris hooks. Overfilling of the anterior chamber just pushes the iris against the lens capsule, and so we need to inject viscoelastic under the pupil margin. Now, this paper by David Chang and John Campbell told us about IFIS. Unlike non-elastic myotic pupils, the IFIS pupil immediately snaps back to its original shape. So there is a matter of elasticity which is involved. So small pupils are of two types, elastic or non-elastic. We must get that concept very clear. An elastic pupil is like a rubber band. It's stretchable. So any pupil expander would work. The rigid pupil is like a string. So it's not stretchable. It needs to be torn. So it needs a strong or bulky expander or Kublen hooks. So we need to check the elasticity or the rigidity of the pupil before we start. We inject a bit of BSS from the side port, and you see that pupil momentarily dilates, and that's a side indicator that this is an elastic pupil. If it weren't, it wouldn't dilate. If it's a rigid pupil, it wouldn't budge. Look at this one. You got fibrosis of the pupil margin, and this is not going to budge. Try as much as you may. So this needs to be torn with two arms. Either you use two Kublen hooks or you use a bulky pupil device like the Malyugin or other devices. So that's going to tear that pupil, and eventually you need to tear that sphincter. So that is before stretch and after stretch. So mechanical dilatation of the pupil, we have IFIS is always an elastic pupil. So if a pupil was dilated when we started and it came down on us, it too is an elastic pupil. There is no doubt about that. So pupil stretching is not required, as neither is it effective. But as it's a rigid or fibrotic pupil, controlled stretching before using an expander is very effective. Whether you use iris hooks or expanders, it doesn't matter. So we have iris retractors, we have the Malyugin ring, we have the BHEX, we have some other pupil expanders too. So what matters most is the elasticity of the pupil and not the size. Now, how big do you want the pupil to be? Aren't we skilled enough to perform phaco through a 5.5 pupil, which will not get smaller? Or most of us would take up a 5.5 pupil if we are sure that it won't get smaller. So why do you want to dilate the pupil to more than 5.5 with a device? That would keep the pupil cosmetically good. And in fact, optically also, it's an advantage. So even with iris hooks, do not be tempted to make it larger than 5.5. Now let's see if the BHEX can do this work. So this is a rigid pupil by Dr. Deepak Megur. Now inject viscoelastic. Tuck the first flange. Once you've done that stretch, you could use the BHEX very easily. This is a rigid pupil. It's a very hard cataract. So it's not that the hard cataract requires a large pupil. As long as, what's happening? Well, stop, yeah. So as long as you can chop it into small fragments, that it does very well. You can use it for any hard cataract, and a 5.5 pupil is good enough. So now we come to the question often asked is, which would be better, iris hooks or any particular pupil expander? Now, so which is the best device? So let's take a close look. Couple of my surgeries. This is a case where I used iris hooks. Now, before I could finish the capsulorhexis, I had iris prolapse of the main wound. It was a mess. The iris was frayed. I was using iris hooks. So there is no shear shot. Now I am struggling with the iris over there as I insert that phaco probe. I'm afraid that it would catch the iris and cause a dialysis. So I had to disengage it. But once the phaco probe has passed the wound, I'm happy. Iris is prolapsing to the side port also, reposited. You can see that sail-like bowing of that iris. And that's again how I disengage that iris from that prolapsed iris from the wound. Again, when I hydrate those wounds, the iris prolapses. So now let's see, I use the BHX pupil expander. Now, here, this is I'm doing a toric IOL in a hypertensive patient, short eye, shallow anterior chamber. I had a hint of IFS, so I used the BHX in advance. Look at what happened. There was no guarantee that they'll not have any iris prolapse. This iris is prolapsing through the side port and through the main incision. So this is a candidate for IFS. So whatever device you use really does not matter. The flow bioparameters and other things apart, it is the severity of the IFS which is in question. That is what causes the problem. Yes, of course, if you have a device like BHX, you can pull it out through the side port, and that is a huge advantage in an IFS case. So in IFS, we have two components, the miosis and the iris prolapse. So if you look at the miosis component, iris hooks and pupil expanders both provide a constant pupil size, which allows good visibility for safe phacoemulsification. That's that. So all devices will allow you that good visibility. When it comes to iris prolapse, actually no device helps. Iris prolapse depends on the IFS severity and the pathological damage to the iris, stroma, and muscles. So we should not give any credit to the pupil device when you don't have iris prolapse. It's just lower grade IFS. So you may get away with a particular device in a case, and in the next case, you may not get away. So that has no significance. So a favorable pupil device in IFS would be one which requires small incisions, has thin vertical profile, and can exit. Minu, if you can permit me, I think we've got enough time. I can take another couple of minutes. So iris hooks and
please go on, please go on.
Well suited. So this is a BHX which you can remove through a 1 mm side port, and it's invaluable when we have iris prolapse or the AC is shallow. Let's look at this. So you just need to hold one of the flanges at the notch flange junction and just disengage it and draw it out. No device can do this, and that is a huge plus. So let's come to a few iris hooks tips. I'd always like to make the side ports. I have not done iris hooks for a very long time. These are very old videos. So we leave a conjunctival mark at the incision, saves us a lot of embarrassment because often we can't find it. So that small conjunctival mark is invaluable. So before we inject the iris hook, we need to retract that stopper far enough, and then we hook the iris, and we do not want to over retract and then advance that stopper. It's simple. And then we make the phaco incision so that we are very safe. So, and one thing with iris hooks, we tend to get a bit carried away. We need to keep that capsulorhexis size in control. And we need to remember that all the pupil margin is antiflex and actually at a plane anterior to what normally it is. It's at the limbal plane. So all our devices are going to get stuck over there. We need to be mindful of that. Now, when we remove the iris hooks, we just need to hold that stopper, advance that iris hook, turn it. It's got disengaged, and just pull it out. It momentarily straightens, and it's very simple. Iris hooks are wonderful devices. We've been using them for many years. If you're comfortable with iris hooks, that's the best device. Now, this is a rhomboid pupil. I think the only case I did, and it's a very bad video. It's a very old one taken from a VHS, so the poor quality. Now, let's look at a few pearls and pitfalls. Now, this is a rigid small pupil, and I was using iris hooks. I was not mindful, so I retracted on the pupil to one side. I did not do a stretch, and the timer can please relax.
Raj, please don't on the timer. We will conclude on time. Don't worry.
So
Yes, sir.
now we can avoid the capsulorhexis by just tenting that pupil margin with the second instrument and hooking that pupil margin. That is a very sure way of avoiding the capsulorhexis. That's a useful tip you can use anytime, especially in a crisis. After the capsulorhexis, you really don't want to hold that capsulorhexis margin. So the second instrument over there can just tent up the pupil margin, and you'll be very clear. And thereafter, you can get all the other hooks in place because you've got one tent in one place. There's few disadvantages, more theoretical maybe. There is a tendency for over retraction. There's a risk of infection, but I'm more concerned about the wasted spaces in the corner. See, those spaces are really not where we have actually retracted and is not serving any purpose. It's that central 5.5 millimeters or 6 millimeters where we're going to work. The rest is wasted space and it's not serving any useful purpose. And it can lead to marks and cosmetic problems. A little bit of sphincter anomaly can lead to glare. Now, let's look at the Malugin ring. Actually, they have the gaps. All of the devices have the gaps on the side. So when you're using a top view from the microscope, you can engage the capsulorhexis margin. That would be a disaster. Whether the BX, the notches are looking at you, you're facing it, you're in full control as you engage the pupil margin. So you do not engage the capsulorhexis margin. Now, here, this is a case where the people came down on me during the case. And this is a hard half cataract that I've left, heminucleus that is left. So I chose to use the BHEX. So what I'm doing is I'm going to now inject viscoelastic under the pupil margin over the capsulorhexis rim and create that space for my device, and then take the leading, just keep it leading flange and tuck it under the pupil margin. There goes the flush flange. As we tuck it under the pupil margin, we draw it to the periphery. So we're absolutely sure that we have not engaged the capsulorhexis margin. And even if we do, we are doing it under direct visibility. We can just retract a little and again disengage and go. So you can always push it to the periphery. And as you carry it to the periphery, you have an instant confirmation that you have not engaged the capsulorhexis margin. Once you have that 5.5 pupil, you can go ahead and finish off that surgery. It's child's play after that. So we are back to your comfort zone. So my choice of pupil expander intraoperative miosis would be either Iris Hooks or BX. And in case of a subluxated cataract, my choice would always be Iris Hooks. Now, what Iris Hooks can do is they can asymmetrically expand the pupil in clock hours of interest. That's what we do. If you saw Dr. Haripriya's videos, I mean, if you have a small pupil and you're dealing that kind of subclass, you want to concentrate on certain quadrants. So you would like selective dilatation in some places, and that can be offered only with Iris Hooks. If you're interested in reading more about the BHEX, you could download this document at medinvendevices.com, the subpage ophthalmic surgeon. It's got videos, links, which are relevant to the text that is being discussed. And you could read a little more on phacoemulsification in small people at eophtha.com. Thank you very much for your kind attention. And thank you, Minu, once again for this wonderful opportunity.
Thank you, Dr. Suvan. So as the last talk, we will have Dr. Chi Soon Fake's talk. Where some is she online?
Yes. Hello.
Oh, that is a real surprise.
Okay, can I start?
Yeah, please, because I was having your recorded one. I was ready
Hello,
to play
everyone.
it. Okay,
First of all, I'd like
please,
to thank Minu for inviting me to participate in this instruction course. And today I'll be speaking on femtophaco advantages and limitations in challenging cases. These are my financial disclosures with no relevance to my talk today. We're all familiar with the dense brunescent cataract. It's difficult to create a capsulotomy because of the absence of red reflex. There's also a thick, bulky nucleus and a leathery posterior nuclear plate to deal with. And therefore, we often have to apply high ultrasonic energy, which may cause a wound burn or corneal edema postoperatively. With the aid of the femtosecond laser, we are able to easily create a perfect, well-centered capsulotomy, and also it helps us with the separation of these leathery fragments because it has been pre-cut. And in this case, I had pre-cut the nucleus into 16 segments, or you can also do grid segments that also help to reduce the ultrasound energy used. So this is a wide intumescent cataract, and we are all familiar with the high intralenticular pressure that is associated with that high risk of Argentinian flag sign as we puncture. Now, if we are successful in decompassing the nucleus on puncture and we do not get the Argentinian flag sign, the capsulorhexis still tends to run away in the mid-periphery because of the swollen lens fibers. So what is the best way to tackle these cases? I like to use the femtosecond laser. So let's have a look at how this performs. You can see as the laser hits the capsule, there was a sudden explosion as the fluid egressed suddenly from the lens capsule. And therefore, it's important to first run intravenous mannitol to medically decompress this lens that's very swollen. Secondly, when we apply the suction cup onto the eye, we want to try to achieve a level dock so that the laser hits the anterior capsule simultaneously and is able to complete the cut. Despite these measures, we may still have an incomplete capsulotomy. And therefore, it is very important to stain the anterior capsule with trypan blue and to check for completeness. And if it's not complete, we want to make sure that we complete this either with a capsulorhexis motion if there are bridges, or if there are text, to just pull radially inwards. In a study that we performed and published, we found that 17% of our capsulotomies in intumescent lenses were not complete, and in the Chinese paper, they reported 10% incomplete. But importantly, none developed the Argentinian flag sign. Now, this patient whose lens is getting Morgagnian, you will see that there is a thick subcapsular fibrosis that has developed, and we will be really challenged to try to tear this and create a perfect capsulorhexis, but with the aid of femtosecond laser, we can get that perfect capsulotomy. Now, when we have a patient with corneal opacity, like what we see on the left, spheroidal degeneration, on the right, granular dystrophy, can we use the femtosecond laser to help our surgery? And you can see if the scar is faint, as on the left, we are able to create capsulotomy and fragment the nucleus successfully. However, on the right, where granular dystrophy causes a denser opacity of the nucleus, it does impede the laser treatment on the capsule and on the nucleus, and therefore we get skip lesions of the capsulotomy, and these cases are best avoided. Now, this is a patient with acute angle closure glaucoma. You can see that the lens is slightly descented and it is extremely shallow anterior chamber as the lens is being pushed forwards, and we'll be very challenged to doing the capsulotomy manually. But this is rapidly done with a femtosecond laser as we scan the capsular bag and center it on the nucleus. So when the patient is brought to the table, you can see the cornea is really hazy because of the high pressure, and we do a limited posterior pars plana approach to dry vitrectomy to decompress the eye, not to make it too soft, otherwise surgery will be difficult. We release the peripheral anterior synechia before starting the phaco. So you can see after the capsulotomy is removed and this was complete, we then support the nucleus with capsule bag hooks and then remove the rest of the cataract. Now, this would be far more difficult to do if we did not have the aid of the femtosecond laser to create that capsulotomy in this very, very shallow anterior chamber and a lens that was descented. Because it was scanned to the capsular bag, we can get that perfect centration of the capsulotomy on the lens capsular bag. So if we have a patient with a small pupil, can we use the femtosecond laser? Yes. First of all, we want to stain the anterior capsule, and then we inject cohesive viscoelastic, following which we inject in a Malugian ring to expand the pupil, and we center this Malugian ring so that we are able to center the capsulotomy with the laser. We then apply the suture before doing the treatment, and once we have done the capsulotomy and the nucleotomy, we then bring the patient back from the laser room to the operating room. At this stage, we are careful to ensure that the capsulotomy is complete. We can see well because of the stained anterior capsule, and then you can see also that this nucleus has been well cut. Right, and this truly helps our surgery. Now, if you do not wash out all the cohesive viscoelastic completely, you may have an incomplete capsulotomy, and therefore it's important to always make sure that you stain the anterior capsule so that you can ensure a safe surgery. Now, in this patient with a posterior polar cataract, you can see the polar opacity is quite large, but the nucleus is quite soft, so I do not put fluid into this eye. After the capsule has been removed, I then put in dispersive viscoelastic just in the subcapsular plane, just where the incisions are. And after removing the nucleus in the center, we're then using our second instrument to pick up the pre-fragmented nuclear pieces towards the center to be phacoed away without the need of having to rotate this nucleus. This way, we are able to minimize the risk of posterior capsule rupture, and Dr. Vasavada, who described this technique, reduced his PCR rate to 4.4% in our study. This was reduced to 7% as compared to 20 to 30% in the past without femtosecond laser. Now we have a more dense cataract. This can be extremely challenging, and I then increased the posterior offset a little higher, and I don't do that for a soft cataract. This is a rather dense posterior polar cataract, and we are going to handle this in a similar way by injecting dispersive viscoelastic subcapsularly in the subincisional areas. I'm not putting any fluid into the eye. And then we're going to start with sculpting a trough in this dense nucleus to create some space so that my phaco needle can sit there and crack the nucleus in the peripheral part of that trough, and then chop the nucleus against my needle in the trough and use the phaco needle to impale that nucleus and tumble it out of the capsular bag, keeping the epinuclear plate back, so that the posterior polar cataract is not breached. And slowly we're able to remove the nucleus in this fashion, fragment by fragment, without rotating the nucleus, and thus not breaching the posterior polar opacity. And now, after the nucleus has been removed, we then remove the epinuclear plate by using linear vacuum and aspirating it carefully. So in this way, we can safely do the surgery without having a posterior capsule rupture. Now you can see this eye that the nucleus is tilted and is decentered, and we're scanning the capsular bag to center the capsulotomy on the scanned capsule so that the capsulotomy is centered to the capsular bag. And then following that, we apply the nucleotomy treatment. Now this patient at the operating table, you can see that the capsulotomy appears decentered, but it is actually centered to the capsular bag. We are making sure that it is complete, following which we apply traction using the capsular bag hooks so that we center now the lens so that we bridge the gap that was seen due to the lens subluxation. After creating the plane with viscoelastic just under the anterior capsule, we inject the capsular tension ring into this plane to expand the equator and keep back the vitreous and prevent the fluid from going from the anterior chamber to the retrolental space. The nucleus has been pre-fragmented and we can easily remove this without even rotating the nucleus. And at the end of the surgery, we add additional support by using a capsular tension segment and suture this with Gore-Tex 7.0, and we have a well secured and well supported lens. So in conclusion, a variety of complex cataracts can be more easily and safely managed with the femtosecond laser treatment than with manual means. And we've shown you dense cataracts, wide cataracts, fibrotic capsules, shallow anterior chambers, posterior polar cataracts, both soft and dense, and most of subluxated cataracts can be dealt with in this manner. Even the faint corneal opacities and the small pupils are not contraindications to the femtosecond treatment. However, there are some limitations, as we showed you, the patient with the granular dystrophy where the opacities are rather dense, lens tilt that is severe, or posteriorly positioned lens conditions which are not amenable to femtosecond laser technology. Thank you very much for your attention.
Thank you
Thank
so
you
much,
very
Dr.
much.
G. Thank you very much. I think we have some seven minutes left for our discussion. So let's take some opinions from Dr. G. So we have seen you using Gore-Tex. So have you stopped using Prolene suture at all? No?
I actually don't use even 9.0 Prolene because there have been reports that after 6-7 years, it can also snap. So I like Gore-Tex because I find it so easily visible and it's suture that's very easy to handle. As long as you make sure that the knot is buried. If you're doing a Hoffman pocket, that your pocket dissection should be at least half thickness of the sclera so that you don't get erosion or exposure. Yeah.
And you have also described a technique to do away with the needle which comes with the Gore-Tex and
Yes.
use it in a different way because the needle
Yes.
is not that very friendly to use.
Exactly. So it's a suture snare, and the concept is really simple. You're just creating a lasso by threading the needle, which I now use a 27 gauge, unlike the publication when I was using it 26 gauge. You just thread, that suture, which is like 45 cm long. It's really very long. You have excess suture. So you just thread it into that needle, and then you capture the end by putting in the syringe so that it doesn't slip. And then when you introduce it, it loops on itself. So that's just a lasso that you just extend and you can bring suture in from anywhere. Yeah.
So have you used our Suven's pupil expanding device, BHEX?
It's not come to Singapore yet,
Yeah.
unfortunately.
Please send it to
Although-
Singapore, Suven. What is this?
Yeah, actually, if just for the record, Singapore health regulatory authority is stricter than US. So yes. So even if it's US FDA approved, we need a local, and there are certain formalities. So it takes some time, and the COVID situation is not really helping at all.
Yeah.
Okay,
that's
Dr.
right.
Dr.
We
Chi,
are-
would
we are-
you
we are-
would you
we are-
suggest that the technique of putting the hook, the ring first, and then taking the patient to the femto and then bringing it back? Is it worth that? Would you
Okay.
suggest?
So I think it really depends on the cornea. It depends on the density of the cataract, whether there are other complications like zonular weakness and so on. But, I have got a few femtosecond lasers in my center, and therefore I use the Zimmer, which is portable inside the operating room. So for those cases, I would use the Zimmer femtosecond laser, and definitely I would use the laser if there is a medical indication for it.
Okay. So, Dr.
I
Venkatesh
just
is
want to
still
add,
there? Yeah.
Professor, some of your videos are always brilliant as usual. All these indications, somehow, way back at home, whenever we see this indication, it is kind of inversely proportional to your financial status, right? Like phacolytics, phacomorphics, the dense brown cataracts, the corneal spheroidal degenerations. All these, we believe that Flax would do a brilliant job, but unfortunately, I cannot afford a Flax for that. And where you land up doing in techniques which is safer in your hands and where they can afford. So that's been a major barrier, at least in India.
Yeah, I understand that. And for us in Singapore, many of these are what we call the subsidized patients who only pay half. So we do allow them to use the laser at half the price if there is a definite medical indication. Yes, because we think it's going to be a safer surgery. They're going to be in the operating theater for a shorter time, and their visits to the clinics will be reduced if we have a safe outcome. So we think overall it's still worthwhile that extra money because it saves cost for them and for the center overall over the long term.
And that's good to know, because we have been kind of subsidizing glaucoma surgeries, people who need a tube shunt surgeries, complex retinal surgeries. But when it comes to a cataract surgery, we subsidized in a safe way of doing a manual small incision, then going them for the other side of the armamentarium to going to Flax.
But if you trace them back, do you know how many retinas and how many glaucomas are a result of complicated cataract surgery? Something that's gone wrong because the surgery at cataract didn't go right.
It happens daily. Yeah. It's happening. As we talk, it's happening.
Yes.
Okay, Dr. Chi, in one of your cases, we saw the capsule retractors on and the CTR going in after that. Have you had an experience of the CTR going in through the loop of the previous model? I know that there is a new model which has come up which reduces that, but do you do anything to prevent that?
Okay, so when Terry Kim described this, I was careful that as I injected with an injector rather than doing a bimanual approach to insertion of the CTR. One hand is pushing the CTR in with the injector and my other hand holds on to the capsule hook and I shake it so that I know I'm not engaging it as I go around. So that's one tip. If you're reusing these and you have this large triangle at the end, you just make sure that you can pull on it and doesn't get engaged as you insert it.
Okay. So in another case, you showed a mega tip or a large tip, flared tip, which is being used in one of those hard cataracts. Do you suggest it in, do you use it in torsional also, or is it just a longitudinal phaco machine? And where do you suggest to use? Where do you get those? Where do you buy those?
Really, I hardly vary my tip. I don't vary my tip according to the density of the cataract. It just happened that I was doing it with that particular machine, but generally I prefer to use Venturi machines, and I find that these are really the best for the very, very dense cataracts, because somehow or the other with Venturi, we use more vacuum, we use less energy, and so it really saves the cornea.
Sorry to interrupt, doctor. We are
Thank you very
out
much.
of time.
That was a great session.
Thank you.
And thank you all the faculty for making it so interesting.
Thank you, Minu. Thank you all.
Thank you so much.
Thank you, Dr. Minu.
Everybody
Thank you,
thanks.
Dr.
I have
Singh.
to thank everybody.